Everyone see my PowerPoint okay?
Yeah?
Yes, we can see
Okay,
it.
perfect. Okay, great. So hi, everyone. Thank you so much for being here today. I invite you to say hello in the chat if you'd like. If you want to share where you're on the Zoom call from, if that's something you feel comfortable doing, you're more than welcome to. I'm super pleased that this webinar was of interest to folks, and it's exciting and definitely a little nerve-wracking for me to have the chance to speak with you all today. A lot of people did register for this webinar, and I hope that you feel that you can take something away from it that's hopeful, helpful, or otherwise informative for you. From my practicing, I don't think we'll be the whole hour and a half today, so I just wanted to give you a heads up about that. My presentation, less questions, is likely to run about 50 minutes, but I wanted to ensure that we had some time for questions as well. So just as a content note before we get into some of the other kind of introductory pieces of this webinar, this presentation will discuss both trauma and eating disorders, including some specific types of trauma, such as historical or intergenerational trauma and systems of oppression, and also eating disorder diagnoses. So anorexia nervosa, bulimia nervosa, and binge eating disorder, for example, will be discussed. I just want to let you know you are welcome to step out at any point in the presentation. This is definitely a difficult and challenging topic, so please do what you need to do. And additional resources are
Get in. I told her. I was like, you were at the house the other day anyways.
I think maybe
Regardless, they're gonna.
Sorry, Charlotte, I muted you by accident as I was muting everyone. So if you can just unmute. Thanks.
Perfect. Thanks for letting me know. Yeah, so if you require phone support at any point in the presentation related to eating disorders, you can call the NETIC helpline at 1-866-NETIC-20. It's open between 11 and 7 p.m. today. And for trauma-related support, please do see this list of resources that's on the slide there. Caitlin is also going to put a link to a bunch of other resources that are available that I'll also be sharing at the end of the presentation. The Sheena's Place website is also a great place to turn to for some resources for crisis and ED support and treatment. So you can visit sheenasplace.org. And you can also message a Sheena's Place staff. So Caitlin, if you are having any, if you're needing any additional supports as well. So I want to acknowledge that I'm not sure where all of you are on the call from today, but I am currently I want to acknowledge the land that I'm currently on and that Sheena's Place is on, which has been the site of human activity for over 15,000 years. This land is the territory of the Huron-Wendat and the Petun First Nations, the Seneca, and the Mississaugas of the Credit River. This land is the subject of the Dish with One Spoon Wampum Belt Covenant, which is an agreement between the Haudenosaunee Confederacy and the Confederacy of the Ojibwe and allied nations to peaceably share and care for the land, and it's also a law that's been in place since the 12th century. The Dish with One Spoon Covenant outlines that we all eat out of the dish, all of us that live on this territory, with only one spoon. This means that to respect this covenant, we have to share the responsibility of ensuring that the dish is never empty, which includes taking care of the land and the creatures that we share it with. Today, the meeting place of Toronto, or Takaronto, as it is also called, is the home of many Indigenous people from across Turtle Island. I'm very grateful for the opportunity to live and work and play on this land, and I also want to acknowledge that this land has been stolen from the Indigenous people who were here thousands of years before colonization. So in specific kind of reference to this topic today, I also just want to acknowledge that the ongoing colonization of these lands has led to the removal of access of traditional cultural foods and relationships with ongoing trauma at the hand of many systems, if not all systems, and a lack of investment in traditional, culturally rooted wellness services. So all of these can impact the development or perpetuation of eating disorders or disordered eating. There should be no conversation about eating disorders and trauma without acknowledging the ways that racism, sexism, colonization, and all of those forms of oppression interact to create circumstances of disordered eating in Indigenous folks and many communities.
I don't want to get tested.
You would have to anyways, going to emerge.
Hi there, just a reminder to everyone to please mute yourself because we can hear it when you don't. Sorry, Charlotte.
No worries, thank you. So I invite you to explore this further beyond this presentation today, using some of the resources included at the end of this presentation. In the words of Gloria Lucas, who's a Chicana activist, educator, and the founder of an amazing organization called Nalgona Positivity Pride, she says, open quote, "We have been left with no other option but to create our own opportunities for representation and healing." And another quote that she has said is, open quote, Beyond the historical trauma and all the harm, our resiliency is the strongest, close quote. So it can be easy to only talk about trauma, and that is definitely the topic of the webinar today, but I also want to acknowledge that the experience is much broader than this, and that it's important to recognize that resiliency as well. So in terms of me, I've gone this time so far without telling you a little bit about who I am. So with keeping the land in mind and kind of my own positionality, my name is Charlotte and my pronouns are she and her. I'm a second-year student in the Master of Social Work program at U of T in the social justice field of study. I'm not a social worker yet, but I will be one in just a few months. And I've had the rather unique experience, as many students have, of completing just over half my degree online, which has been an adventure. I'm also a practicum student at Sheena's, and I hope to honor throughout this presentation what an immense privilege it is to be a witness to the stories of folks who have experienced EDs, including at the intersection of various types of trauma. I really do love this work very much, and I'm learning so much along the way, thanks to the vulnerability and courage of folks in Sheena's groups. This particular webinar was actually, I came up with this topic thanks to reaching out to friends on Instagram and seeing what kind of topics they wish, especially folks with lived experience, wished people knew about EDs. And so I'm also grateful to people who reached out and shared a little bit about their experiences with me. I won't be quoting anything in the presentation, but it was definitely kind of the spark for this presentation today. So before Sheena's, my professional experiences have been in a bunch of settings, mostly focused on youth mental health education, sexual violence prevention, and group and workshop facilitation. I also previously completed my Bachelor of Education and have lots of experiences working with little kids, which I love. In terms of my identities, as mentioned previously, I am a white settler on these lands. I'm a thin-bodied and able-bodied queer woman with lived mental health experience and post-secondary education. And each of these identities interact with my relationship to this topic in many ways. As a disclaimer, from what I've learned, both from the people who have shared their stories with me and also the research that I've done, it's really important that presentations about trauma don't ignore the types of trauma that arise from systems of oppression. Too often this is ignored and not treated like the trauma that it is. But I also do want to note that I hold a lot of privilege, especially in eating disorder spaces, and that some of the perspectives that I'll share here are not lived experiences that I hold. And instead they're being shared from those who do have those experiences. Also, this, as I mentioned, this hour and a bit conversation is not going to present the whole story. Trauma stories are not the only narrative of those who experience trauma and ED. So those who live at the various axes of oppression that I do not have experience with, especially around race, might have significant experience with trauma and ED and also have stories that are way more broad than I can tell today. I'm reminded of an Instagram post that I've seen, which sadly I could not track down to cite. I am a bit of a millennial, that say, and I paraphrase, that while trauma can be passed down in families and communities, so can resilience, resistance, and joy. I definitely encourage you to continue learning and taking action, as is also my responsibility to do, and seeking out the resources at the end of this slide deck. So with the knowledge that I'm a student and I hope to always be a learner, I hope that you'll provide me with feedback in the feedback form following the presentation, and also that you will share any questions that come up in the chat throughout the presentation. I'll also do my best to answer them, and Caitlin and Kelsey may step in to add their thoughts as well. So in terms of a few guidelines for this group space, a reminder that this isn't a support group, as Caitlin mentioned, but an educational webinar. So the guidelines are a little different here than in another Sheena's Place group if you have attended one before. I wanted to acknowledge this is going to be not the most discussion-based webinar. I am mostly going to be talking at you, which is not my favorite way of presenting, but I also know that it's not the way that everyone learns best. So please do feel free to step away from your screen, participate in whatever position and way feels most comfortable for you, and do whatever you need to do in this space. So pretty much take what resonates with you and leave what doesn't. Also, if you bring up a question that was missed earlier in the discussion because you were taking a little walk around your bedroom or whatever, that's totally okay, and there are no silly or repetitive questions here. Please also do what you need to care for yourself during this time, where generally, as I've mentioned, this is a really challenging topic, and lots of folks here may have lived experience of either trauma or eating disorders or both. And also, when we're thinking about this, how can we care for each other in this space? And in the spaces outside when we participate in discussions about trauma. So how can we be accountable to talking about trauma in the ways we talk about triggering topics outside of this webinar? And maybe that also means committing to giving a heads up when you're talking about a potentially triggering topic Maybe it means learning more so that you can become more acquainted with the ways that eating disorders and trauma intersect. Or it could be interrupting and taking actions on the systems of oppression that impact eating disorders. You're welcome to keep your camera off, as mentioned. Zoom fatigue is super real, and whatever version of yourself that you bring today is welcome. When asking questions in the chat, please make sure to use I statements in order to avoid generalizing and speaking on behalf of experiences that you may not hold. And I may not have all the answers, and some things I might say might not resonate with everyone's experiences, but I hope that together we can make this a space of accountability for one another. As mentioned too, I'll stop a couple of times during the presentation for any questions. If I see lots of questions coming up in the chat that need to be answered, then we will try to address those when we can.
Charlotte, if I can quickly jump in, and we've had a couple of folks ask if you can speak a little bit slower so they can keep up.
Yes, thank you so much. I definitely do that when I'm nervous. I'm going to try to talk more slowly. So knowing that some of you may be very familiar with the eating disorder and trauma world and some might not, I did want to do a quick rundown of a few terms and acronyms that I'll be using. So first of all, ED is an acronym that you'll see come up quite a bit in my slides. And I just want to acknowledge that not everyone who lives with disordered eating accesses a diagnosis of a disorder, and not all people who experience disordered eating feel that the DSM-5, which is the text that's used for diagnosing these disorders, fits their experience. So eating disorder here is used as a shorthand with recognition that it does not fit all experiences. There's also a huge shortage of diagnostic services for those who do want to access those services. Second, I'm going to be using the language of victim/survivor when coming to topics about trauma and people who have lived experience of trauma. That is just to acknowledge that not everyone who has experienced trauma identifies as a victim, and not everyone identifies as a survivor. Some identify with neither. So this is used within the context of trauma and not usually within the context of ED, but I'll mostly use the term lived experience when talking about ED. A couple of other shorthands, AN, BN, and BED stand for anorexia nervosa, bulimia nervosa, and binge eating disorder, which are 3 disorders I will use shorthand for in these slides for brevity. I also just wanted to note that I'm going to be using the language of trauma responses rather than calling them trauma symptoms. Rather than pathologizing trauma, using trauma responses allows us to perceive trauma, the things that happen as a result of trauma, as expected and understandable responses to a traumatic event. Complex trauma is something that is not talked about enough, unfortunately, but it's essentially a term that encompasses the exposure to multiple chronic traumatic experiences and the long-term impact of these experiences. They can impact personality factors, relationships, and also begin in childhood with an impact continuing into adulthood. This isn't an official diagnosis as of yet, but the experience of complex trauma is one that is now being recognized as a distinct set of traumas and trauma responses. And it's also more and more being used to describe lived experience of systems of oppression. So I'll come back to that a little bit later on. I also just wanted to mention that I am going to be using the words fat and fat phobia and bigger bodies to describe folks who have that lived experience of the most serious forms of weight stigma. And I want to identify that when I use that word, it's used as a political term and descriptor. It is a term that when I'm using it in this way has been stripped of the pejorative connotations, and it's been reclaimed by a growing fat acceptance movement. That being said, not everyone who lives in a bigger body does identify with that word. So I did just want to say that, and it's really important to try not to control the terms that others use to describe their own bodies. So with that, I will share a couple of objectives for today. Am I talking a little bit slower? Is that feeling a bit better now? I can slow down a bit more. So I don't know if there's been any more comments in the chat about that.
We have, everyone has a different preference. Some folks are saying it's still a bit fast, and others are saying that it's perfect. So
okay, I'll slow down a little
You're
bit
doing
more.
great.
Thank you.
Thanks.
Thanks, Caitlin. So here are some intentions and kind of objectives for our space today and what we're going to talk about. So what we will cover is, first of all, an introduction to types of trauma and their impact, including common trauma responses. Second, explain the relationships between eating disorders and trauma. to describe some existing treatments and strategies for EDs and trauma, unpacking some areas where research is lacking, providing tips for considering trauma when supporting someone with an ED, and also sharing resources for further learning. I just want to acknowledge that something this workshop will not cover, kind of as Caitlin mentioned earlier, is coping with EDs and trauma, as this is not a support group space. So I just wanted to acknowledge that just so that folks are on the same page about kind of what we'll be discussing today. Okay, so with that, some of you might be super familiar with trauma, and some of you, this might be some of the first times that you're hearing about it. So just to provide a definition of trauma, it's defined as the lasting emotional response that often results from living through a distressing event. Experiencing a traumatic event can harm a person's sense of safety, sense of self, or ability to regulate emotions or navigate relationships. And this can often extend long after a traumatic event occurs, with people feeling shame, helplessness, powerlessness, and sometimes intense fear as well. I really like this image by What is Mental Illness on Instagram. Again, I have a few Instagram mentions in this PowerPoint today, but it really just shows how broad trauma really is. This can be the experiences of chronic illness, not chronic illness in themselves, but maybe the way of interacting with medical professionals, and pain and all of these different things. Poverty, pregnancy loss, racial oppression, medical trauma, cyberbullying. There are just so many different types of trauma that can emerge from this. And as you'll see in the next slide, the responses to trauma that people can develop are just as wide ranging. In terms of diagnoses, trauma is most commonly known to develop into a disorder called post-traumatic stress disorder. However, other mental illnesses can also coexist or be triggered by traumatic events and life experiences. Disorders such as OCD, anxiety, depression, and personality disorders, and yes, eating disorders can coexist with PTSD or the lived experience of trauma. Each of these diagnoses and their corresponding symptoms or signs can have various amounts of stigma ascribed to them, which can also really prevent people from accessing support. Like eating disorder diagnoses, not all folks who fit the description for a PTSD diagnosis want a diagnosis, are able to access one, or feel that the diagnosis accurately reflects the entirety of their lived experience. It's super important to note that due to a variety of factors, including biological, personality, emotional, social, compounding trauma, so that means like having multiple types of trauma that you've experienced, and the constancy of trauma, so is it ongoing or long lasting? People do experience trauma differently, and what's traumatic for one person may not present with trauma responses for another. This doesn't mean that those symptoms will never emerge or those responses, nor does it mean that it is impossible for those with those trauma responses to manage them with appropriate access to care and resources. Okay, so these are just a few different types of trauma responses. And as mentioned earlier, the way that I personally approach trauma is that trauma responses make sense given the circumstances a person has been in and is currently in, which is why I usually prefer to use the term trauma response rather than trauma symptom. I did want to mention that in about a minute or two, I'm going to briefly mention the pandemic. So please do take care of yourself if this is a trigger for you, or if that is distressing to listen to. So traumatic events do push the nervous system outside of its ability to regulate itself. So for some, the system gets stuck in the on position and the person is overstimulated and unable to feel calm. That can be when anxiety, anger, restlessness, panic, and hyperactivity can come up. It's kind of this ready to react mode. The physical state of hyperarousal, which is what that's also called, sometimes also hypervigilance, those kinds of things can be really difficult on the body and really challenging to deal with. In other people, the nervous system may get stuck in the off position, which can result in things like depression, disconnection, fatigue, and lethargy. And many people can also alternate between these highs and lows. Most people do experience both of those kinds of experiences. Trauma responses, such as those listed on this slide, things like hypervigilance, anxiety, self-harm, dissociation, and hyperarousal, are all a product of the body trying to respond to a distressing situation. Sometimes that can be after the danger has passed, and sometimes it's when the danger is ongoing. As an example of a type of collective experience that many of us are going through at the moment, though in differing ways, the pandemic might mean that lots of people are experiencing some level of hyper-awareness or hypervigilance. So This is a normal response to a challenging threat that helps us stay alive and hopefully stay safe from COVID. An example of this might be the response of being more aware of the personal space around us at the grocery store or pharmacy, for example. It's worth noting that this might be a hyper-awareness that many people with chronic illness or people who are immunocompromised who lived with this kind of fear pre-COVID and at a greater intensity than those who are not. But it's also an example of how hyperarousal can be brought on by stressful or often traumatic events. Sometimes trauma responses can also happen because experiencing the emotions of the trauma can be too painful or unsafe. And enacting these responses like dissociation can act as the protective force for folks. For those who aren't familiar with it, dissociation is where a person may experience disconnection from their thoughts, feelings, memories, or sense of identity. For example, it can happen in the moment of someone experiencing an acute trauma or at other times throughout their lives. Even though I think like for many of us, if we've started talking about mental health, oftentimes like the approach is you just need to talk about it and that kind of thing. Dissociation might not seem like a coping strategy to an onlooker without context, but it is something that keeps many alive in order to enact that fight, flight, or freeze response when they're experiencing a traumatic event, and it can protect them from remembering the event or other similar ones in the future. So these are just two examples of the ways that trauma responses demonstrate that our bodies do what they need to keep us alive. They're incredibly intelligent. Trauma responses are adaptive to their specific circumstances. However, repeated instances of this kind of response, such as a fight or flight response you might have heard of, can be very difficult to manage and even lead to serious health and mental health concerns. So now that we have talked about trauma for a bit, I want to bring things around to eating disorders and disordered eating. As I will describe in the next few slides, trauma and ED are often related to one another, and there's still quite a bit of research on why that is. But it's become quite clear in the last few decades that trauma often presents itself in the body, sometimes before showing up in someone's cognition or awareness. So in the way that sometimes people aren't necessarily aware that they've experienced trauma, but their body might be showing symptoms or reactions to trauma. So as mentioned before, trauma can lead to that dysregulation of the nervous system when we enact those fight, flight, or freeze responses, switching on or off in moments of trauma to protect us physically, mentally, or emotionally from a traumatic experience. Disordered eating can both be a response to trauma in itself, so kind of included with these mistrust, hypervigilance, anxiety, anger, and it can also be a coping strategy to manage other trauma responses. So if someone is experiencing dissociation or they're experiencing self-harming behavior or something like that, ED can also be linked to those. So in order to understand the relationship between EDs and trauma, it's important to also understand some commonly held beliefs about eating disorders and who can have them. So in terms of a couple of myths, many people believe that eating disorders are always about food and relationships with food directly. Lots of people also believe that EDs are always about body image and that those who have them always fixate on their bodies. There's also a belief that eating disorders only affects the people we most commonly see struggling with them on TV. So often that's white, thin, cisgender, middle-class women, and that EDs are caused exclusively by the media and physical depictions of thinness. So in ads, in magazines, that kind of thing. Perhaps some of these are beliefs that you yourself hold because they're so normalized wherever we go, whether we're watching a TV show or movie, talking to friends who aren't familiar with diet culture, or at times even interacting with medical and mental health professionals. These myths are very widespread and common. Many people with eating disorders might also internalize these messages, especially regarding who is likely to have an eating disorder. So for those of you new to the eating disorders world, what you may not know is that eating disorder myths tell either none or very little of the whole story. First off, eating disorders are not always about food, despite many eating disorder behaviors being associated with food. Generally, recovery does not involve healing one's relationship with food alone, as there are many other factors involved related to mental health that also need addressing. So for others, food may not be the trigger, but is a coping strategy for other concerns or stressors. Second, EDs are not solely about body image, and not all people with EDs fixate on their bodies or appearance. Because of the way that the media depicts EDs, there is a thought that they always involve body self-criticism, but this is not always the main concern. Some folks will avoid thoughts about their bodies needing dissociation or distraction, while some others may find it difficult not to have body thoughts or to body check all the time. And then third, while most people think of white, affluent, thin, and cisgender women being most likely to have eating disorders, they can disproportionately affect Black, Indigenous, and racialized folks, trans, queer, and gender nonconforming folks, those living in bigger bodies or fat folks, and those experiencing food insecurity. It's also super important to look at the environmental and social factors associated with this. So I've kind of mentioned some of those systems of oppression, rather than these identities themselves. Having an identity does not necessarily preclude someone. It's not like a specific to that identity so much as it is specific to the context around that identity. ED support is also harder to access for the groups of people who are disproportionately affected by them, and it's also less likely to provide support in a way that meets these folks' needs. So there's also a myth that in order to experience disordered eating, one must have food security or affluence. And despite beliefs otherwise, eating disorders are not only experienced by people who have food security, as food insecurity and poverty have both been seen as risk factors for ED as well. Individuals living with food insecurity have been seen to experience feast or famine cycles in which food intake varies according to fluctuation in food availability. So for example, food intake can decrease during periods of food scarcity and then increase during periods of relative abundance. So that could be right after a paycheck or after a government stipend, that kind of thing. After restriction, restrict and binge cycles are more likely to be maintained due to the cognitive, emotional, and physical side effects of restriction on the body. Finally, though the media and social media do perpetuate body image dissatisfaction, which is a leading risk factor for the development of EDs, media and social media aren't solely responsible. As seen with these other eating disorder truths, eating disorders are complex illnesses that cannot be traced back to one particular source alone. So all this to say, eating disorders are complex and they're not always presented as such. They're not purely genetic or biological, nor are they purely social and cultural. There are many things that may lead someone to experience an ED or disordered eating, and one of those factors is trauma. So all of these myths add to the stigma of eating disorders and the erasure of those who have them, which can in turn reduce help-seeking behavior for those with eating disorders. The way these myths continue to live in our systems, including health systems, is incredibly harmful and can also mean that folks are unable to get the support that they need or deserve. So I'm going to pause here. I know that I've been talking a lot. I wanted to see if there are any questions coming up that want to be answered at this point in the presentation. Maybe just open the chat.
Thanks, Charlotte. So you're welcome to unmute. If anyone has a question, you can unmute yourself and ask, or you can ask in the chat. There is quite a lot of commenting going on in the chat, so I'll just remind everyone to please try to only use the chat to message everyone if you have a question that would be beneficial for everyone to see. Otherwise, you can message me privately, Caitlin, or our second tech support person who has arrived, Kelsey. So you can message the two of us with tech questions, just so that everyone's chat isn't exploding here. And then you're welcome to ask questions that you have for Charlotte in the chat. So at this point, does anyone have any questions?
Hi, it's Heather here. I have a question. I'm sorry, I got really distracted by everything going on in the chat. And Charlotte, I missed pretty much everything you just said about eating disorders and like the systems and stuff involved. I know it was quite a bit of information, so you may not have time to summarize it right now. But I'm wondering if there's a smaller summary, or maybe I just need to wait and go when it's recorded and just go back and go through it myself. I'm not sure if there's anything you can point to in short. I think it was mostly what I missed was yeah, just how like EDS and how sometimes EDS, a person, for instance, like myself, might not necessarily identify with certain DSM things. I believe that's what you were pointing to, and how that can contribute to trauma. But I have a little bit of difficulty understanding it. I hope what I said made sense.
Yeah, thanks so much, Heather. Yeah, I thank you for also letting me know that maybe that needed some repeating. I saw a couple of other people nodding as well, and I will kind of come back to this a little bit later too. But I'm really glad you brought that up. So essentially, because of the way the DSM is designed, and also like the origins of this of psychiatry, some people don't necessarily feel that this reflects their experience. There are also quite a few like models of looking at mental health as kind of what I've talked about, like within this context of the larger world being in some ways quite traumatic for folks in itself. And so I think that because of that, there's sometimes like feelings that the DSM is both like a super Eurocentric or Westernized approach, and doesn't necessarily meet everyone's needs or reflect their experiences. And also there's people who have accessed psychiatric care and have not felt it feels safe for them. And so there is that as well. I don't know if that kind of answers, or if you have any follow-up questions to that, I'm happy to answer that.
No, yes, that kind of answers the question. Thanks so much, Charlotte. If I have any more, I'll just ask again. Thank you.
Okay, perfect. Yes, please do. Are there any other questions from folks?
I also have, oh, sorry, go ahead and I'll ask mine after.
Okay, thank you. Hi, Charlotte.
Hi.
I am wondering how this compares to substance abuse and how someone gets addicted. How is eating disorders different?
Yeah, I mean, there's some people who do feel that kind of comparing the model of the experience of an eating disorder and the experience of substance use can sometimes be like similar. Some people do kind of call it an addiction, or they find it find that sort of aligns with their experience, though not everyone does. I'm not an expert in substance use, and I actually haven't done a whole lot of work in that area. But folks who do use substances, like there is a connection with eating disorders as well. I don't know if Caitlin knows a little bit more about that and wants to jump in, but I'm not super familiar with that area of expertise. So,
well,
yeah, for sure. Sorry, go ahead.
Sorry.
I was just going to say what I was focusing on more is that the substance abuse is trauma related a lot of times, and so is eating disorders. And I was just trying to figure out what would make some people turn to eating to numb themselves, and others would turn to substances to cope.
Yeah, I think, yeah, Caitlin, you go ahead. I see you've been.
Yeah, no, I was just going to say, I think that actually connects really well to another question that I received here on chat about the functions of eating disorder or disordered eating symptoms. And so for a lot of people, from my experience, like you said, the underlying issues might be similar, but the way that a person copes with those issues might look different. So it could be around eating behaviors and food or exercise or substances. So the question that I got here was someone saying, I'm wondering if you could explain how disordered eating can be a coping strategy to manage other trauma responses. So I know, Charlotte, you spoke to this a little bit, but if there's anything you have to add there.
And I'm actually about to speak to that in a moment too, so I'll get into that a little bit more. Okay. But there are, eating disorders do serve a whole number of functions when it comes to trauma and coping with trauma. Yeah, I see that someone even said like food produces the same internal feel-good chemicals that substances do, and that definitely, like, those biological effects can be similar for some folks in some cases. So I definitely do want to acknowledge that. And then I just see one more question, and then maybe I'll get back into the presentation and we'll have more time for questions at the end. So I was just wondering if you could comment on if there is anything you've seen in your, is that okay, Caitlin? Were there other questions earlier, actually? I should have checked.
No, I think that's all I've seen.
Okay, I scrolled through them as well, but I just wanted to make sure. If you could comment on if there's anything you've seen in your experience about the biological responses of trauma. Yeah, I think, I mean, I don't know if I can speak specifically to my own experiences in terms of like my work experience and volunteer experience, that kind of thing. Because oftentimes like they aren't experienced in a biological sense for the person who's experiencing them. So they might feel more social, even if they are driven by biological like experiences or like internal kinds of responses. But there are some really good books and information on kind of how trauma does show up in the body. So some of those are in the resource package. And I definitely recommend checking out more about that. I don't know if that answers your question.
Yes, thank you.
Okay, perfect. Thanks. Okay, maybe I'll get back to things now, and then we'll have more time for questions a little bit later on. Okay, so kind of related to what we were just talking about, I do want to share a little bit about what some functions of eating disorder symptoms are as trauma responses. And I'm going to try to speak more slowly as well. I know that there's still been some comments that it's a little hard to follow. So disordered eating can be a response to trauma in itself and a coping strategy to manage other trauma responses like dissociation, hyperarousal, and awareness of the body, shame or anxiety, as well as many of the other trauma responses that have come up. And relationships with food and sleep are often some of the most affected when folks experience trauma. So as a result, eating disorders can be a response to the trauma in itself, and other trauma responses that can be distressing or uncomfortable. So for example, food can become something someone can control, whether that's restricting or not, when other things do not feel in control. EDs can also serve functions such as self-harm, which is a very complex phenomenon with a number of different kind of motivations behind it, depending on the person and their experience. A way to avoid sexuality, especially if someone has experienced a sexual trauma, such as childhood sexual abuse or sexual assault. A manner of avoiding painful or triggering feelings, self-soothing, or coping with negative self-image. So all of those different things can come together as functions of supporting some of the uncomfortable and difficult feelings that someone might be experiencing after experiencing trauma. So with this knowledge, you might be wondering what kinds of trauma are actually connected to eating disorders. There was some early research done specifically on the relationship between childhood sexual abuse that found that around 30% of patients with eating disorders did have a history of childhood sexual abuse. However, many other types of traumatic experiences have also been associated with eating disorders in the research, and these include things like sexual assault, sexual harassment, physical abuse and assault, emotional abuse and neglect, teasing, and bullying. It's worth noting that while childhood sexual assault and childhood sexual abuse and sexual assault can be high risk factors for ED, this kind of trauma can also be related to experiencing body image disturbances more generally, and this can play a part in the development of eating disorder behaviors and symptoms. So in terms of trauma and eating disorders and their connection, trauma is frequently responsible for removing one's sense of control and agency, whether this is experienced as an adult or a child. Eating disorder symptoms can be a manner through which to access control when trauma has limited or removed that. And in that case, that can actually cause some of that dysregulation of the nervous system. And again, this can be an attempt to regulate that. So this is kind of going back to the question earlier around systemic traumas. So systemic traumas and long-term traumas, including historical or intergenerational trauma. So that's meaning trauma that's been passed down through generations in a community or family, are also linked to eating disorders. Trauma studies, unfortunately, frequently focus on interpersonal types of trauma, although this is very important as well. But there is often a failure to acknowledge the way systems of oppression play into the development of ED. EDs do need to be understood in terms of the impacts of weight stigma, diet culture, racism, and colonization, as well as many other systems of oppression, and how these impact someone's likelihood of developing an ED. So I am going to talk a little bit about kind of some themes around that and some examples. I know that that was kind of a question earlier. So for example, Sabrina Strings, who is an author and scholar, discussed in her book, Fearing the Black Body, The Racial Origins of Fat Phobia, how Black people have historically and intentionally been linked with fatness and fat phobia dating back at least 300 years. Recent articles have also highlighted how nutrition advice is often centered in whiteness, and this often can create further trauma for Black folks who live with disordered eating. One wonderful Black anti-diet dietitian named Christina Johnston notes in a recent Instagram post, again, here's me doing my little Instagram post shout out, open quote, Black folks who experience white spaces are continuously assessing for harm and actively trying to reduce it. This chronic hypervigilance allows for eating disorders to thrive. They often go untreated due to bias and lack of safety to treating professionals, close quote. So as you can see, this kind of hypervigilance is something that is experienced by many Black folks all the time, and is one of the reasons that it's really important to talk about how eating disorders and other types of systemic traumas are linked. There's also been a study on medical erasure of racialized folks more generally, their experiences of eating disorders broadly. And in a study of people with self-acknowledged eating and weight concerns, racialized people were significantly less likely than white participants to be asked by a doctor about their eating disorder symptoms. So this just shows that those things can get missed, often leading to not being able to access treatment. And oftentimes these are also related to some of those myths that we talked about earlier. I also just want to acknowledge that sizeism and weight stigma can also create complex trauma for folks who identify as fat or who live in bigger bodies, who may experience interpersonal and systemic trauma in medical settings, in social settings, and in a whole bunch of other settings. There are a couple of articles listed at the end of this presentation that mention how doctors and medical professionals have encouraged weight loss in those in bigger bodies to a detriment, ultimately leading in folks developing eating disorders. Though health is often concerned presented as a concern for people in bigger bodies, fat phobia and weight stigma may mean that folks are denied the care that they need and that they constantly can face those microaggressions and worse health outcomes. I also did just want to note that Gloria Lucas, who I mentioned earlier in the presentation, who's the amazing founder of the Nalgona Positivity Pride, a really great body liberation organization, discusses in a recent article the relationship between eating disorders and trauma for Indigenous communities. So she talks about some of those things that I spoke about earlier, such as the removal of opportunities for ceremony, traditional medicines or traditional knowledge about the land, and destruction of the natural environment due to climate change, and how all of these issues are related to eating disorders. So there's more information about that in some of my sources. Lucas also discusses how important it is for those who are Indigenous to be able to access that land and those traditional foods and medicines, as well as support from elders and other community leaders to experience healing from eating disorders. So I did just want to share the statistic, which is quite gendered, as many eating disorder research is, as much eating disorder research is. And I know I don't use a ton of statistics, but I do find that some people find them helpful. One study did show that 75% of women who have enrolled in residential treatment have experienced some form of trauma, while 50% of that 75 were shown to have a specific history of PTSD, so that diagnosis of the disorder. So you can see that this is definitely a very pressing issue related to eating disorders. So in terms of what the research says about trauma and ED, this is kind of building a little bit more on some of those other themes, knowing that there is also a lack of research in some areas, which I'm going to talk about in the next slide. So history of trauma is more common in those with eating disorder diagnoses that involve bulimia symptoms. So for example, binge eating disorder and bulimia nervosa. Research findings linking eating disorders and trauma have also been extended to children and youth and to boys and men. So even though there are many studies that mainly have women, because women are more likely to access, cis women in particular, cisgender women are more likely to access treatment, there is definitely a large gap in terms of the research that exists on boys and men in particular. Even though 1/3 of people who do have eating disorders do identify as male. Multiple episodes or forms of trauma are associated with EDs, as mentioned, and also having more than one type of trauma, so that like compounding trauma that might layer on top of each other can also lead to a higher risk of ED. Trauma is also associated with a greater likelihood of living with other mental illnesses, such as PTSD, but also diagnoses such as OCD, depression, and anxiety in those with eating disorders. And then finally, also research findings do indicate that treating trauma symptoms is needed, as well as treating eating disorder symptoms in order to facilitate a full recovery from the ED. So that doesn't mean that somebody could not make considerable progress in recovery from their ED without addressing the trauma, but working with trauma is seen as an important part of treating the eating disorder. So while there has been a good deal of research on ED and trauma, there are still quite a lot of gaps in the formalized research. This said, there is lots of information from community members on the impact of EDs in their communities, including those listed below, and this should not be discounted as valuable knowledge in itself. So first off, more research is needed on the impacts of complex trauma and the link between it and eating disorders. Such work is underway, but there's still limited research, especially because it's not identified as a diagnosis in the Diagnostic Statistical Manual, again, that book that's used to make diagnoses. Research is also still heavily based on the gender binary. I realized I didn't define cisgender, and it might be a term that not everyone is familiar with, but essentially cisgender means folks who identify with the gender that it was assigned to them at birth. So oftentimes right now, the research is very focused on either cisgender boys versus cisgender girls or women, boys or men versus cisgender girls and women. And queer and non-binary and trans folks are disproportionately likely to experience eating disorder symptoms and trauma as well. And again, despite the fact that 1/3 of folks with EDs are male, there is still a very limited research on that as well. It's also worth noting that binge eating disorder is disproportionately experienced in marginalized and racialized communities, and it was only added as a diagnosis to the DSM in 2013. So there's still a lot of very much limited research on the disorder and its links to trauma, unfortunately, but hopefully that will be addressed in the future as well. There's also a lack of universally accepted measure for complex post-traumatic stress disorder, which I mentioned before, which has led to higher levels of dropout in treatment programs, often because those treatment programs have not actually been designed with complex trauma in mind and folks' needs when it comes to complex trauma. So some of the treatments that are available for eating disorders and trauma, it's worth noting that, as mentioned, integrated treatment, so treating trauma and eating disorders at the same time is kind of known as the gold standard for treating these two. However, there's not a whole lot of knowledge about how to do that in some spaces, unfortunately. There are a few studies that show that there's more people who are getting familiar with treating trauma in eating disorder spaces, but there still needs to be more education and knowledge among healthcare providers as well. It's worth noting that there is also very little research on treatments that integrate support for complex post-traumatic stress disorder, in particular when it comes to eating disorders. So DBT, or dialectical behavior therapy, is one of the very popular treatments for under-controlled disorders like borderline personality disorder, substance use, bulimia, and binge eating. So again, often those are conditions that can exist with an eating disorder as well. And that's been shown to be helpful for folks who have experienced trauma. Radically open DBT or dialectical behavior therapy is kind of an alternative approach that is meant for over-controlled disorders, which are disorders like chronic depression, chronic anxiety, anorexia nervosa, and some personality disorders as well, like obsessive compulsive personality disorder. DBT was also originally designed for borderline personality disorder, which is often tied to experiences of trauma as well. And then, yeah, radically open was developed later on to treat some other illnesses. So trauma-focused therapies have also been shown to be effective. These can include things like cognitive processing therapy, eye movement desensitization, and trauma-focused cognitive behavior therapy. I'm not an expert in any of these, so I won't get into them too much, but they have been shown to be useful for folks who have experienced trauma and in some cases folks with EDs. And body-based approaches are also growing in popularity. These are things like somatic experiencing, and basically the principle behind that is that trauma is often experienced in the body. As mentioned before, sometimes people are not even aware of the trauma that they've experienced as a protective mechanism, and therefore treating the ways that trauma shows up in the body can be really important. In terms of more general support, and maybe not in like a treatment sense, group settings for movement where appropriate, expressive arts and peer support have also been shown to be super supportive for those who have experienced EDs and trauma, which is what we do at Sheena's quite often. So that's great as well. So I just have a few more slides left. What does it mean to support someone or work with someone who is experiencing both ED and trauma? You might be wondering, what do I do with this information from this presentation? So I just want to share a few points with the knowledge that there are probably many other things that folks with EDs and trauma want you to know, but I'll share a few things that might be helpful tips. So first of all, if someone approaches you to share about their trauma or their ED, it's important to practice consent. We often think that consent is just about sex, and it's not. This can include following their lead in terms of what they need support for and what they feel safe talking about or sharing with you. When it comes to reporting or connecting them to other resources, this is especially for healthcare providers or mental health care providers, considering how you can be as transparent as possible around kind of what the line is where you would need to report, as well as not involving resources that clients don't feel safe using. Just making sure that you're doing all other options before turning to those that they don't feel safe with. As a friend or caregiver, this might look like not overstepping their boundaries and respecting that sharing all details about trauma is not always what's most helpful. I think in the world of people learning to talk about mental health, there's a lot of push to talk and to be open, and that's not necessarily going to be what someone with trauma needs. It might be and it might not be, but just following their lead and acknowledging that sometimes, sharing all the details can lead to re-traumatization or triggering for someone with trauma. Second is believing survivors and victims of trauma of all kinds. This can include complex and ongoing trauma, as well as intergenerational and historical trauma. Gaslighting is a huge issue that can just add further trauma to what someone is experiencing. So believing someone when they have the courage to share with you what's going on in their world is super important. And even expressing that aloud can be really helpful. It also can take a lot to trust someone with your trauma, especially because that trust and control have often been taken away. So acknowledging that can be really helpful. And I just want to acknowledge too that this includes trauma that's ongoing. If someone is currently in a traumatic situation and they've decided to share this with you, it does not mean that they need saving or rescuing. It's really about listening to what their needs are and centering their sense of self-control over the situation. Also acknowledging and understanding the role that control plays in eating disorders when one has experienced trauma. So you can do this by providing choices, maybe researching options together if someone is looking for treatment or support, and if it is helpful for them to discuss it together. Go on to the next slide. A couple more things to consider. Making sure that you're being patient and compassionate, and again, not rushing or forcing someone to share about their trauma. Oftentimes when someone is sharing a story with us, we might want to know those why answers and those why questions, which can often come across as blameful. So avoiding those kinds of questions when discussing trauma with someone can be an important part of providing them with support. Remaining non-judgmental and listening, which might seem obvious, or just sharing space with them if that's what they need. So if they don't need to talk, but they just need someone to be with them. Obviously, it's a little bit more challenging during COVID, but maybe offering them some virtual support or just a space to do whatever it is that they need to do. Also acknowledging one of the myths that I haven't spoken about yet, but that eating disorders are not a choice, despite being an illness that has many behavioral aspects. Eating disorders are not a choice, and acknowledging and knowing this can help to reduce some of those feelings of needing to fix or solve what's going on. So that can help make sure that you're staying focused on the person who has survived or experienced the trauma, and not rushing what they're going through. So I had reached out to someone on an amazing student therapist on Instagram who shared this wonderful post a couple of months back, and their name is Laura at the Mind Health Spot on Instagram. And Laura asks in her post, what if our society saw certain mental health issues as understandable responses to our problematic and oppressive systems and environments, rather than as individual pathology? And in the second part of the post, she notes, what if instead of putting all the responsibility of recovery and healing on the individual, we shifted towards a collective responsibility of wellness? And I think this is really important and worth noting, with all this discussion about what kinds of treatments are available and where the research is lacking, there's such clear indications that folks who are experiencing trauma, every day of their lives, what is really needed as well is to actually address those traumas at the root, and to ensure that folks can feel safe living in the world. So I just wanted to acknowledge that, and I really appreciate this post from Laura that made me think a little differently about the way we approach trauma in different spaces. My voice is getting tired. Okay, so just in terms of that, one of the myths that can be shifted or changed when talking about EDs within the context of trauma is that EDs are not a choice. Within the context of trauma, or essentially by taking this trauma-informed or maybe even trauma-aware approach, we can approach eating disorders with the knowledge of the complex ways that they interact with people's lives, identities, and other traumas that they've experienced. Acknowledging this can allow for less shame and self-blame about the ED on the part of the individual who's living with one. And it can also help create more supportive relationships for those who live with an ED and their family, friends, and loved ones. So that is the end of my formal part of my presentation, but this is a lot of text. I just put this on here in case anyone was not able to download the PowerPoint, but it's all in there. Or not the PowerPoint, excuse me, the link that Caitlin put in the chat. So I've just got a bunch of Instagram handles that you can follow. Of course, these are just kind of inciting ways to start to think about some of the things, and doing more research is always great. Instagram posts are not, despite the fact that I mentioned a couple of them, they're not the only source of research and knowledge, but they are a source of research and knowledge. So I definitely encourage you to check these out. These include folks who are working in environments including dietitians, social workers, and therapists. They're also folks with lived experience of different kinds of identities that do intersect with these issues. I also haven't vetted all of them, and I haven't gone through every single post, but you can see kind of what speaks to you from the posts that are available there, and see if there's anything that works for you. This is also in the link that Caitlin shared in the chat. I don't know if maybe Caitlin, you've shared it again recently, but maybe doing that just in case if folks want to check them out. So we do have a bunch of resources on that sheet for eating disorder treatment. These can include NEDIC, which has a helpline for finding information and referrals about programs, both for treatment and for support more generally. There are a bunch of hospital treatments in the GTA, excuse me, and you can find more information about that at ocoped.ca, ocoped.ca. I said that really fast. It's ocoped.ca, and that can be really great for finding out more information about treatment programs that are available. There's also private and virtual treatment available at Body Brave, which is OHIP covered, and they offer treatment to folks who are 18 plus. At Homewood, which is paid private in-person treatment, age 16 plus, and then private therapists available at NEDIC, or available to find out more about at NEDIC at least. They have kind of a directory of those. There's some options for virtual support here, including Sheena's Place. As Caitlin mentioned, registration is on Monday at 10 a.m. for Sheena's Place groups, and it's free group support for those age 17 and over. There are also a number of other support group organizations that are available online, virtually, depending on where you are in Canada. And there's also virtual support available internationally through FedUp, Nalgona Positivity Pride, as I mentioned earlier, for Black, Indigenous, and racialized folks, age 18 plus, and the Eating Disorder Foundation. There's also some links for caregiver support there as well. So if you're attending today as a caregiver or somebody who supports someone with an ED, you can check those out too. These are just some great resources that are great for learning more about EDs in general, so you can check those out. Unfortunately, the links didn't work on the slide, but they are available on that link that Caitlin did share in the chat. So I encourage you to check them out and read them. I did mention Fearing the Black Body, the Racial Origins of Fat Phobia during this presentation, which is definitely worthwhile reading in order to learn more about that topic as well. Just a few podcasts that you might be interested in as well. Dietitians Unplugged, Food Heaven, Food Psych, Racist Sandwich, and Body Justice. And I encourage you to check those out if podcasts are one of your preferred methods of learning. They're really great, and they've got a whole host of different topics. Some of them do focus on trauma, and some of them just on eating disorders or diet culture more broadly.